I'm really looking forward to this afternoon, having worked for 20 years with children and TACers, and seeing young transplant recipients blossom into young transplanted adults has been a great pleasure to me over many years. But yes, it's true, some of them did fall by the wayside and had trouble with their medication. And so I know only too well how important this subject is. And I'm really excited to be working with Ashley and with Paul, who is really the guru for me of transition, having worked getting these children to come to our camps. And then many of the people that looked after these children knew of Paul. And when I said I worked with Paul, they were very excited, because Paul has really done a lot in this field. I believe 60 people that have signed up, so I hope they'll all be here. So with no more ado, I think I'm going to now move on to introduce a fabulous lady that you can see on your screens, who's nodding and sitting in her car. Her name is Ashley, and she's from the USA. Ashley received the gift of life, a liver transplant, from her younger sister several years ago. I first met Ashley in 2016 when she became one of our first ambassadors for the World Transplant Games Federation. Ashley is rather amazing. She is the co-owner of the Tumbling and Trampoline Gym in Huntley. She has a master's degree in exercise psychology, and she's been directing a recreational program for 3 to 18-year-olds for a long time. She's been coaching for over 20 years, multi-sports, including track and field, volleyball, and of course, tumbling and trampoline. She is the mother of 2. Not only that, she also homeschools. She really is a superwoman. She was a female athlete in the US team for Malaga and for Newcastle. And this lady, I can tell you, is really passionate about promoting organ donation and transplantation and tissue donation. She's passionate about children and educating children and getting them moving. A little bit of trivia. One day I was walking along the street with Ashley, and I don't know what came over her, but she decided to do a backflip. So if you see her in person, you can ask her for a backflip. I promise you she will not disappoint. Ashley is someone I am really proud to call a friend, and I'm absolutely ecstatic to have her as a colleague on the World Transplant Games Federation board. She works on the Athletes Advisory Commission, and she is the chair of Transplant Next. So Ashley, it's over to you, my love.
Thank you very much, and welcome to everybody for joining us today. A little bit about Transplant Next. It is an initiative of the World Transplant Games Federation, and our main goals for Transplant Next are just to really encourage the participation of transplant youth in sports, and highlight the benefits of sports and exercise in young transplant recipients. We also want to encourage participation in future World Transplant Games, build a community and platform where like-minded people like yourselves and athletes can share their stories and engage with others. And then lastly, one of our main aims for Transplant Next itself is to provide education platforms and helpful information for both youth and their parents. So like this webinar, for instance. Through Transplant Next Conversations, which is what we're doing today. It is just a way for us to provide helpful information for both youth and their parents, families, and caregivers. So we appreciate you guys for joining us today for that. And it's our hope that we at Transplant Next Conversations itself will create and allow a safe place for questions to be asked, concerns to be raised, and a platform to discuss various topics, which in our case today, we do have our very first Transplant Next conversation titled Youth Transplant Recipients Transitioning from Pediatric Care to Adult Care. We just want to help anybody during their transplant journey. And so with more about our topic and introducing our guest speaker, I'm going to throw it back over to my colleague, Liz. So Liz, take it away.
So yes, Paul Harden. Paul Harden, who trained as a nephrologist and transplant physician at Western Infirmary in Glasgow. He is a consultant nephrologist with a special interest in transplantation, and worked many years also at the University of North Staffordshire. He developed an interest in non-adherence in young adult recipients and during transition from pediatric care to the adult services. He's a clinical advisor to the National Health Service in the UK on adolescent transition on young adult services. He is also the chair of Transplant Sport UK. He's been my slave, a volunteer at TACA's, and a fabulous volunteer as a doctor, and also at the World Transplant Winter Games. So he is someone that is really devoted to transplantation and transplant sport, always ready to roll up his sleeves and get stuck in. It's a real honor to work with Paul. He's a fabulous man. And a little bit of trivia for those in Hong Kong, listen carefully. He loves that strawberry jam with the rose petals. So I will give you his address later to send him some from Hong Kong.
Okay.
So Paul, over to you.
Okay, well, welcome everybody, and thank you very much for joining this session. I hope that we will get some good discussion. I've got a few slides to show first as a means of introduction, to talk a little bit about the problems behind moving from children's to adults care, which is generic really to many chronic illnesses, not just kidney disease or liver disease or heart disease and transplantation. And also then some ideas of how we've, over the last 15 or 20 years, tried to develop ways to make this easier for the patient and their families, and particularly the parents or siblings. So let me just see if I can share my slides, whether I'm going to get this to work. Hopefully it is going to work. So, obviously, this is the London Underground, and as you know, in some stations, if you're not careful, you can fall down and electrocute yourself in between the train and the platform, because it's all a bit old. But I think Mind the Gap is a really big, a good synonym for this, or synonym for this problem, which is how do we deal with the gap between pediatric and adult care? And most children's hospitals are very different to adult hospitals, and most care in children's hospitals is very different to the much more independent care that you get as an adult. And so there needs to be a sort of phased approach to this. So one of the issues, I think, is continuity of care. And many of you may have experienced that actually you're suddenly switched to adult care, you're under different clinicians, you've not had any interface, and the continuity of care is completely eroded. So that's one issue really. And the second issue really is about trust. Most people that that have childhood illness are looked after by a very small team in the children's hospital over many years, and develop huge trust for that hospital, that team, and have huge anxiety about moving to another centre, particularly if it's not the same hospital, and it may well be in a different city, and sometimes occasionally a different country. So that causes a lot of anxiety amongst the particular individual, but also particularly amongst the parents or the next of kin. And then there's this issue about peers. It disappoints me that even in children's hospitals, if you're an adolescent, there's a lack of peer interaction often amongst the other patients in a similar situation. And I think peer interaction and peer support can be very helpful at times when it's difficult in life, to have that support from other people in a similar situation. And we see that a lot, those of us that participate in the Transplant Games, of the huge value of doing things with people in a similar situation where you can discuss your illness quite freely and everybody really understands where you're coming from. So I think peer interaction is important. So really what we're talking about here is how do we develop a integration between the pediatric service and the adult service? And the first thing is the difference. I mean, I've mentioned that they're poles apart, and they often are. On the left here is the part of the Evelina Children's Hospital waiting area, which is really quite child friendly. What I would say about children's hospitals are they tend to be child friendly for maybe the under 10s, and not necessarily quite so child friendly for the teenager, so as you get closer and closer to the transition period, you get further and further away from this type of environment. But this is an American dialysis center waiting room, and the most noticeable thing here is that everybody is probably, apart from this one chap here, over the age of about 50 or 60. So one of the problems that we have in adult care in all of our services is that the population of patients we look after has a median age of about 60 or 65, and that applies to most specialties, but particularly to the kidneys world. So that's an issue, quite difficult for a young person to integrate and have much in common with all these older people. So we get this, where do these young people fit in here, or do they fit in? And then we have this problem that here we've got a typical inpatient in an adult unit, and here we have a young chap as an inpatient in one of our hospitals who is showing this to the camera because he just doesn't want to be in this environment where this is the person in the bed next door to him. So how do we cope with that? And what we're trying to do really is keep people out of hospital like this guy as much as possible. But if they do come into hospital, how can we make it easier for them? And how can we make it easier for their immediate peers and family to cope with being an inpatient in the environment of mainly an elderly population? That's challenging, but there are things that we can do. Why have we got a problem? And Liz alluded to this problem. She mentioned that she's experienced several people where they've gone off the rails. And here we have 20 people. So if you look at this here, this is kidney function for the year leading up to the transfer to adult care of these 20 patients in the UK. Pretty stable, different levels of kidney function, but all a flat line. And I think you'll appreciate that that flat line within 12 months of transfer to adult care disappears. And 35% or 7 of these 20 individuals go off the rails and effectively lose their transplant early. And this could have carried on like this for many, many years, but this has happened. And this is a common phenomenon, which is associated with moving from pediatric to adult care, and is disastrous for these 7 individuals because this shouldn't have happened. And they've all lost their kidney because of the pressures and the stress of moving and becoming more autonomous and losing their transplant, mainly because they've stopped taking the medication for various different reasons. And recently in the UK, this data was analysed. So they compared teenagers and young adults with perhaps a more stable age group of 30 to 49-year-olds. And you can see here that transplant failure in the teenagers was 26% higher, but a return to dialysis was 41% higher, and 41% stopped attending clinics regularly. So then what this really means is almost 50% increased risk of the loss of a transplant when you move from pediatric to adult care or during that age range. And it's not just about the UK here, because we're talking the World Transplant Games Federation here. So I've got Sweden now. So this is data from Sweden. And this shows 38 patients who are transplanted in the Swedish Pediatric or Children's Centre. And then this is when their transplants failed. Now, a few failed in childhood, mainly for technical reasons, because it's difficult to transplant very young children. But look, the dark blue is where most of the failures have occurred. And you'll notice it's between the age of about 13 and 23. So this is the danger zone, if you like. Most of these later transplant failures are because they had a transplant for 15 or 20 years. But many of these transplants were lost within 1 to 5 years of being transplanted. So these are failures due to not taking the medication predominantly, and having various different social things that have created that situation. So what are the sort of issues here? Well, most people transition by the age of 18, because most children's hospitals, particularly in many countries, won't look after patients who are older than 16 or 18. So the first thing is a total lack of trust in the adult team. And in fact, occasionally they may have got the perception from inadvertently from clinicians or from the culture that their children's hospital is a very specialist center because it covers a huge area. And being transferred to an adult hospital is kind of like a downgrading to a place that is more local to where they live and isn't perhaps viewed quite so importantly. So the children's hospital might be known nationally or internationally, whereas the local center people might not have heard of so much. So there tends to be a lack of trust in the adult team from the outset. There is often poor continuity of care. So often the patient is just transferred to adult care, doesn't know who they're being transferred to, and it may be that they see several different doctors over their first few visits in adult care, maybe a junior doctor, somebody who might not know their condition very well. So there's a problem with continuity of care. There's, as we just seen, a stark cultural change in the appearance of the unit. in the ethos of the unit. So there's a very big team in most children's hospitals. There's a very small team in many adult hospitals, and there's an intention that people look after themselves very independently from day one in an adult centre, whereas they may have had many multidisciplinary support before that. There's peer pressure. So if you're at school, if you're at college, if you're an apprentice, if you're embarking on life at 16 to 18, you will be mixing with lots of individuals who don't have a chronic illness, and they may point fun of you because you've got a chronic illness. They may alienate you. They may want you to be like them. So there's in the media, everywhere, there's a tendency to perform to the, if you like, the ideal individual. So there's peer pressure from that point of view. It's common, as you know, for young people not to get car insurance very easily because they can have accidents. And so young people take risks, and risks that we wouldn't consider doing, a young person might do. And therefore, going away for a weekend and forgetting your medication, they probably wouldn't think too much about it, whereas we would panic. So there's risk-taking behavior is a phenomenon in this age group. And there can be covert non-adherence. And sometimes somebody has been not taking the medication for quite a long period of time that even the Children's Hospital haven't recognized. And then it just comes to a head after they've transferred because they've become more autonomous and they might have stopped taking the medication completely. So be aware of that. And finally, it's not a process. So transition is a process over a period of time, but unfortunately, in many centres still, it's a one-off transition or transfer, to care to the adult setting rather than a formal integrated process. So those are some of there are other issues as well. There's obviously the issue of the impact on the wider family and the parents, which I'm sure we will discuss. But it's a very difficult and challenging moment for most people who've been particularly looked after for a long period previously. So what we tried to do over the last 15 years or so to overcome this is to develop a much more integrated process. So this part of this scheme diagram here is all in the pediatric hospital up to this point. And this is all about preparation from the age of about 13, 14, it needs to start early, to the ultimate move into adult care, which is over here. And basically what we have evolved is to, let's go back, sorry, back one, is to have an integrated approach where we have joint clinics at the pediatric center. So where a youth worker, Daly, who hopefully is on this call in a minute, and myself go to the Children's Hospital 3 or 4 times a year and have a joint clinic with the pediatric team and see patients that are headed for our direction. So they live in our geographical territory, and we start meeting them from the age of about 15 onwards. And we would see them jointly for 2 to 3 years, not just on one occasion. And during that period of time, we will arrange a visit to the adult unit because most people are a bit scared of what it's like where it is, without any clinical appointment, just to show them round. We will do a joint decision over transfer, which is with the parents, with the individual themselves, and with the pediatric and the adult team, all involved in that process, so that we can say, what is the ideal time for you to transfer? It might be when you're 17, it might be when you're 19, and being flexible about that. And during this period of time, we will introduce a buddy scheme. So we will introduce them to some other patients who've transferred to our unit over that period of time, who can be a supportive peer. And we can also arrange some support for the parents or the siblings if that's required. And you can see here that in the pediatric center, we're moving towards a situation where there's a teen clinic, so they're seen from the age of 15 onwards. And there's a parents' information evening, which is evolving around this. So what this is all about is a progressive transition of care over a significant period of time, which will vary and needs to be customized according to the individual and what they want and how they are, what their issues are and what their problems are. And for some individuals who've got other medical problems, it may be integrated with other services. And then the question is then what do you come to? Because I've showed you what an adult clinic looks like. And one of the problems is that we don't offer a specialized service for young people. So what we've developed in Oxford is a separate young adult service. And this comprises predominantly a transplant physician, a youth worker, and support from a nurse practitioner and a pharmacist, actually, and if required, a psychologist. And here I've shown you integrated transitions. So initially we will see these patients in the pediatric hospital, but eventually we will then move them into a customized young adult clinic for 16 to 25-year-olds, which would occur in a community-based setting, but also where people need to come, let's say somebody who's been recently transplanted more frequently, we will try and cohort or group together the young people that are coming to the same clinic at the same time. So in other words, it's a very limited team who specialize in this area. There's absolute continuity of care, and we don't use other clinicians in this setting, which I think is really important. Daily, the youth worker, and in a minute I'll ask him if he can say a little bit more about this, works alongside this and can provide one-to-one support by reaching out to the hospital and going to visit the patient at home and their family, take them to activity events which are outside the hospital, and can arrange group activities with other young people, so that we have developed a young patient community within our setting. So it's very much about a continuum from the, say, 15 to 16 onwards to the age of about 24, 25. And some people say, well, what happens at the end of that? Well, it will depend on the individual. For some individuals, they may wish to leave that process at 19 and just be seen in a standard clinic. And for other individuals, they may stay involved in this until their late 20s. So it just depends what that individual needs and their requirements are. But the point is, it's a service developed for them specifically, rather than just being absorbed into the standard adult service. And just as an example of a community clinic that we've run in the past, and COVID has affected us a bit, so we're reformatting this, but basically this would be where the patient would come and say, patients come at 10 a.m. in the morning as a group. They then go for a coffee session with the youth worker, which is an informal period to exchange views and chat. They would have a lunch at the clinic. There'll be a games room. And then during all this process, I would see them in a clinical setting as for their clinic appointment and take their blood in this sort of a setting. So as you can see here, the patient may actually be involved in this process over a period of 4 to 5 hours, rather than what tends to happen for most young people that go to hospital is they go in there, they sit around for however long they have to wait, they're seen, they have their bloods done, and they want to get out of the place as quickly as possible, and they have no interaction with other young people at all. And so we're trying to sort of break that mold, really. And then we've run some activity clinics. So these clinics are outside the hospital. You can take blood on a barge out for the day. If you have a thing like this on a UK canal, you can get the young adult patients to interact with one another by opening the locks, driving the boat. And that breaks down the barrier and helps to generate a sort of community, a young patient community. And it could be a zorbing session, it could be a theatre trip, or it could be an activity event, shared experience and peer support and the introduction of it, and developing a network of people that can support one another who've been through the same situation. Here we go, a pottery class, for example. So does that sort of thing make a difference? Well, I showed you what happened to this UK population previously, and then we've been following our data for a period of time. And certainly for the first 3 or 4 years, this is 12 patients who've transferred as opposed to 20, but in one centre, we didn't have any transplant losses. So a very different picture. And I think that that's largely due to not the medication, but the way that we've been running the service and the support that's put in place. So what I would say, stress highly here, is that it's not about changing drugs. It's not expensive interventions here. It's about changing the way that you run your service and the use of utilizing the resources that you have, particularly of personnel and particularly of other patients in a similar situation. Come back to that one actually in a minute. We've taken this technique. So now this has been adopted largely in all of the centres in London and in the southeast of England, and in some other centres in the UK as a phenomenon. And there's more and more youth workers now in place in the different centres. And we developed a joint link with Aarhus in Denmark. And we took a group of our patients to Denmark in 2014, and we had a weekend. And we found 18 Danish patients who were all late teenagers or in their early 20s. Not one of them had met before. And we took them for a weekend, and then subsequently following that, they set up a similar sort of young adult clinic service, and it's been running ever since. So this isn't something that has to be just in our centre. You can develop a similar thing elsewhere, but you need the clinicians to want to do this. And the Danes came to us and said, can you help us? And so we went there. We've been there a couple of times. We've had 3 different joint weekends with them now, and we're about to have another one. And so you can sort of propagate this idea elsewhere. So my key messages are, unfortunately, most of our medical services are like this, inflexible and don't change, and are very historic the way that they're run. This is the Hundertwasserhaus in Vienna. I like this. This is an apartment building. That's what we should be doing we should be customizing our apartment buildings and our services to the individual rather than this monolithic approach. So we need to individualize the process according to the person's circumstance, which often isn't the case. We need a very clear partnership between the pediatric and the adult team, which is closely related, so that I meet I know all about this person and their medical problems because I've been in a clinic room with the pediatricians that have been looking after them for a long time. And it looks like we're running the same service, and it's just a continuum, not just some remote name that I'm suddenly going to go and see Dr. Harden in Oxford. Never met him, don't know what he's like. He could be terrifying. And all I've got is a letter to say, go and see Dr. Harden. They will know me because I've been there for 2 to 3 years meeting them with their parents. Whilst they're not under my care, they're still under the pediatrician's care. And I'm not going to change the medication. I mean, the big mistake that a lot of people make in this situation is suddenly to say, oh, well, we don't do it this way, so you've got to change to this type of medication. Completely wrong thing to do. Nothing wrong with what the pediatricians have been doing. They're real experts in their field, and we should follow their advice and their strategy. And then maybe if we tweak the changes, they'll be very minor over a period of time. Make the service youth friendly, do it at different times of the day, make it flexible, arrange some activity events around it, and engage peer support, which I've shown you examples of. And I can't emphasize enough the value of having a youth worker. And at the end of it, then you'll develop a young adult patient community.
Well, that was fascinating, especially that chart at the end when you see the difference that what your work makes. It's really astounding. I just wish that every centre would be able to do something like that. I think a lot of centres would probably say it would be a problem of funding and lack of time. How did you manage to get past those hurdles?
So, I mean, I hear that a lot, or we've heard that a lot. People have said, well, it's really difficult. You first of all, you need a bit of passion to change things, but we're not seeing more people, we're just seeing them in a different way. So the first thing is to get the concept across that let's pull these patients together. The first thing you can do is say, they're going to be coming to clinics anyway. Let's get somebody who can relate to these people easily as a clinician, and then let's get them all into one clinic as opposed to spaced different clinics so that we can then bring them at the same time and they can meet one another. And it can start as just a coffee session in the coffee shop in the hospital, for example, and an informal chat, which maybe one of the clinical team can sort of facilitate. And then, you will find that we've all got parents, we've all got patients who are resourceful and can fundraise, and some of whom are business people and will generously give donations. And you don't need a lot of money, but a little bit of charitable money that comes from that source can then enable you to run a few events. And then I was lucky that we applied to a UK charity for funding for a youth worker, and we got funding after having a volunteer for 2 or 3 years. And it was one of the actual living donors to one of the other patients who was a similar age, who operated as a voluntary youth worker initially. But then we got funding from this charity for 3 years. And then we got some data that I showed you, and the data is powerful. So if we can show that sort of difference, that saves money. And if you can show that in your unit, then you can get money from your state, in the UK's case, from the NHS, to pay for a person who can act as a facilitator for this. And what I would say is that I've seen other centres around the UK, they're now moving towards using youth workers, but they first started off with nurses. Well, this age group don't want somebody who is regarded as another member of the clinical team. They don't want a nanny. They want a buddy. And so they need a young person to do this. And so and people have cottoned on to that now, certainly in the UK. So it's a different type of role to having a specialist nurse who's coordinating things. They want somebody that can relate to them, knows about the latest rap music, knows about the latest thing that is hip amongst somebody who's a similar age. So that's what we're looking for. So you can do it, but you've got to have somebody who wants to drive it, basically. But patient power can drive this sort of thing. So if you see that your centre is not doing something, I would say to any of the patients and families on the phone on this webinar that, you know, do get out there, do see what's going on in your units, and if it's not, if you're not providing something specifically for young people, then question that and say, well, why aren't you doing this? It's possible.
Yeah. We have 33 people on this call, but I don't know exactly what all the different people, what their role in the world of transplantation is. I know we have some recipients. I know we have some doctors. I know one mummy that's on this call who her child had her first transplant when this kind of thing doesn't exist. So Romina, would you like to, I'd love to hear your comments on Paul's presentation and how you went through the whole transplant story when, you know, you were pretty alone out there when I first met you.
Yes, it was, it was a pretty lonely world. You know, until we came to join in on TACAs, we thought we were the only one dealing with such a situation. It was quite overwhelming, actually, to realize that we weren't. But the transition was definitely difficult from youth to adult services. All of the slides you showed, all of the graphs you showed, we go, yes, exactly, tick. We'll have that one, going from lovely child services to a waiting room, a windowless waiting room, surrounded by older people, you know, and it was really tough.
Yeah. How many years ago was this? It was like 2005?
Well, the transplant was 2003, but
we can't see you. I'd love to see your lovely faces and introduce my dear friends. You haven't done your makeup, have you? That's the thing. So we've actually got Romina and Delise on this call, and Delise received a kidney from her mum. There they are.
Hello.
Hi, darling. So, you know, we've got both sides of the story here. What would you like to tell us about your journey, Delise?
So the transplant happened in 2008. Oh no, sorry, 2003, when I was 8 years old, and my kidney failed fully when I was 19 years old, and the 3 years leading up to that was the transition phase, and it was difficult going from a team that I'd known since I was 2 years old, you know, and to then going to a clinic where people didn't even know my name, and they couldn't pronounce my name properly, and they didn't know me, and you know, she had
to go through procedures that I'd always attended and always held her hand and always been with her throughout everything.
You're not allowed to attend?
No, it was the first procedure I had done as an adult was getting a line fitted for dialysis, and having it done under local was really scary. You know, when I was at the children's unit, they'd always like sedate you or something for procedures like that, and it was quite a
traumatic.
Yeah, it was, you know, to put it bluntly, it was a bit traumatic.
And I couldn't attend, so that was the first occasion that, after having been by Delisa's side since she was 2.5, when she had her first diagnosis of a kidney tumour, to then sitting in the waiting room, twiddling my thumbs and knowing that she was going through something traumatic there. I could have been with her when, you know, we're so medically versed now that it would, you know, I would have been, anyway, I think I would have been helpful for her.
Definitely.
To be in there.
I see Peter had his hand raised. Peter, did you want to ask the ladies a question, or you have a comment? Don't forget to unmute, Peter.
Well, just a general comment. Thank you for your impressive explanation and your very impressive stories. And although I'm one of the old guys, I do recognize things from the younger people I've spoken to. My question was, there are more than just transplantee kids that transition from youth to adulthood. There are other chronic diseases. Is there any cooperation ongoing with other types of chronic diseases to make this, as I understand, I've tried to find out how many kids there are, and it's generally a very small group, which makes it more difficult to get the attention, to get the things organized. And if you can combine it with other groups that basically have the same issues, maybe you can create some mass in which it becomes more easy to organize in hospitals. So, have you any experience with that?
So, yeah, there are lots of chronic clinical conditions that require. So, for example, rheumatoid arthritis. There's people with inflammatory bowel disease. There's people with diabetes. The problem is that they're similar in the sense that they're moving from pediatric to adult care, but they all have substantial differences in how they're affecting the individuals. There are some commonalities, but there are also some specific differences. So, for example, in transplantation, one of the biggest issues is immunosuppression, but that might not be an issue for a diabetic person or somebody with rheumatoid arthritis, for example. So most hospitals are approaching this with a transition policy, and there can be some generic sharing of concepts, but most of the patients want to talk to and share experiences with other people who've been through the same situation. And that's, for example, having a line put in, we just heard about, having a PD catheter putting in. To want of a better thing, what happens about having sex, for example, when I'm on peritoneal dialysis, when I'm 18? What about body image issues, which may not be quite the same for somebody who is perhaps got chronic epilepsy, for example. So there are some commonalities, but I would say that there needs to be some specific approach in terms of bringing those peers together to support one another. So yes, there needs to be an overreaching service, and most big hospitals are now thinking about that. And there's been the idea of having a coordinated transition service for at least 30 years, actually. But it's only recently that people are being, if you like, developing more focused skills towards that. So in our setting, there are a number of different youth workers working in the different specialties. But one of the problems is, you're right, it's a small number of people. And therefore, to make it work, you probably have to consolidate those small number of patients into a university setting or center where you can pool enough patients to actually support them as a group. I don't know whether at this point, Daly might, if he's on now, I think he is, might want to say a little bit about the support of patients going through procedures. And also, if I go back to those pictures again, Daly, are you there? Come in, Daly. If not, actually, to talk to Delise, Daly just goes to the radiology suite with any young person who's having a line put in now and sits with them. And he obviously is like there are some issues about family members, and it's got more difficult since COVID, going into, for example, a radiology environment where you're using X-rays, for example, which had been taken during the procedure. So therefore, he gets to know these individuals usually for some time beforehand, and so he would be the support. So in other words, we try and get around that situation. Not everybody wants their parents. Some people do, some people don't, but we provide somebody who is, if you like, the patient's advocate in that situation. And I don't see any reason why others couldn't do the same, really.
Colin has a question. Colin, are you there? A question or a comment from Colin?
Yeah, I think it's kind of been addressed by Peter's comment on the kind of having enough numbers to make it practical, that it's like small countries, happily we don't have a huge number of patients in this age profile at any one time. So I think my question has been addressed, to be honest.
I think really, though, it really boils down to the person. So Paul is this fabulous doctor, but Paul, anyone can chat to. He makes you feel at home. And I think quite a few doctors are not that at ease with chatting like we're chatting now. My transplant surgeon, when a doctor friend came to see me when I was in the hospital when I had my transplant, when he introduced himself and told him he'd sent him a patient, he said, "Oh, well, I'll leave you to it then," and backed out the room and shut his head in the door on the way out. So, I mean, he's a very good surgeon, but interaction and having to talk about things, I think he prefers people who are under anesthesia.
I think that's a good point, and I think actually, I think sometimes doctors have to realize their limitations, and not everybody has the skills to deal with this age population, and each center needs to find out who is the best person to run this service. And instead of saying, well, I can do everything, actually some people need to admit that actually they should pass those patients over to that individual to look after them. And you wouldn't believe how resistant, when we set the service up in Oxford, some of the other consultants were, oh, we don't need that, we've all got teenage children, we know how to deal with that. But that's different to dealing with this kind of environment where you've got a chronically sick individual who it is important that you have an empathetic approach and an approachable, being an approachable situation. So I think you're right, Liz. I mean, some people, it's not just doctors, it's some nurses aren't very good at it either. And in fact, there's no training in this is the other thing I would say. So I feel that if you're going to run this type of service properly, then each larger center needs to identify an individual or individuals that are going to run this service and train them. You know, they should spend 3 or 4 months in working in pediatrics to get to know a little bit about how the pediatricians work, what the pediatric diseases are, because they are different to adult diseases, and they should get to develop a relationship with the pediatric center. And Colin, what I would say about size, when we started in Oxford, we had 6 patients, and we still managed to run a service that supported those 6 patients. So I think that even if you're coming from a country which has a small population of this age group, the key thing is get them together. It doesn't matter whether there's only 5 or 6. It's better to have the 5 or 6 get together rather than they're all running in their own isolated scenario somewhere else. And some years ago in Boston, in America, they ran a young patients clinic, and the patients flew to the clinic. So if this clinic, if this means enough to the patients, and if they get enough out of it, they will travel the distance to go to it. Even if it means traveling, 100 or 200 miles to go to the clinic, it's probably only 3 or 4 times a year. And with social media technology now, once you've met face to face for a couple of times, then you can interact much more successfully like this on Zoom and on Teams or other types of social media such as Facebook or Instagram. So utilize all the things that young people do, I think, is the way I would say it.
Thank you, Paul. I see Philip Wood has his hand raised. Philip, would you like to come off mute and come online?
Oh, hi, you okay? I'm sorry I haven't got my video working today. I've just got 2 children under nephrology and my child liver transplant, so it's a bit of a crossover today. It's a massive learning curve, which has been, most of the questions have been answered. But what seems to be common is that there's only a small pool of patients. I see women's liver transplant, they have all these issues. And is there any way of these different specialists coming together? Because a lot of these children, my son has so many issues with the liver team and the experiences you've described, and my other children under nephrology, it seems to be different areas, but maybe for the trusts rather than it as a whole, possibly going forward, bringing these children together from the liver and the kidney area. I'm not sure about other areas, but it seems to be very common across.
Philip, may I ask you the age of your boys?
Oh, sorry?
The age of your children. May I ask you their age?
Yeah, my one child who's had a liver transplant, he's 8 years old, so I'm just trying to get as much information at this stage. But my other 2 children are under nephrologists for their rare conditions. They haven't, obviously, they haven't got the risk of a transplant. It's only my child who's had a liver transplant. But I just thought, just listening, just to get an idea for when he's older, it's really useful to listen to everybody and stories, which is fantastic. But maybe as a trust going forward, can have a look at bringing these different areas together rather than looking at it singularly, because these children are experiencing the same sort of things across the board.
Of course.
And the isolation, which is really worrying.
I think it would be helpful for you as a parent to, lobby the trust, get together with other parents in a similar situation and make them aware of what you feel about this and what else is available elsewhere, because in Leeds, for example, there is a big kidney program and a big liver program. So, and there's some very enthusiastic people that work in both. So I don't quite see why it wouldn't be possible to develop a joint program there. But not every hospital has multi-transplant organ transplantation. So therefore, in centres where that does exist, it makes sense to pool resources. I think that would be a very good idea. You know,
you know any of the other parents at your hospital, or is it like the people in Boston where they haven't met each other that Paul mentioned? I think we've lost Philip.
Sorry, can you hear me now?
Yeah. Have you met any of the other parents, or are you in contact with any of the other parents with a sort of similar situation?
We're in contact on liver mum. It's more a lot of the parents don't seem to have that sort of relationship with the clinicians as close as they'd like, and they help each other out. And it just seems there's a lot of isolation across the board when they're coming up to their adolescent age, and there's a lot of these experiences. And it seems like the parents are getting together online, but they're not joining up with the clinicians to try and drive this forward. It's quite a shame on the liver side.
Yeah.
So it'd be nice if
what centre your child was transplanted in?
Yeah, it was at the Birmingham Children's Hospital.
Yeah.
But there seems to be a help unit just for the parents where we're all online, but they seem to discuss it directly with their consultants, which is quite worrying. I do myself, because I think that's vital, but there's a lot of parents on there which they don't like to be kicking a fuss up or speaking directly to the consultants, and which is a real pity, I think.
It is. I think quite a lot of people, you know, of all ages, often they don't dare say things, you know, they sit and listen and say, okay, and they're not their own advocate because they don't dare say what they're thinking, which is always a great pity. I think information, being informed, makes you more powerful and takes fear away. And I think it's very important. But maybe it should be you, Philip, to do this lobbying and get them together.
I'll certainly love to have the time. I do drive it forward as much as I can, but with my 3 children with conditions, it's
that's huge.
It's also
huge. Yeah. Well,
got
Philip,
autism and difficulties. I do my best to speak directly to consultants.
I really hope that moving forward and you know, things will become easier, and this will become a normal thing to have when we have young people that have had transplants. And you know, again, with all different kinds of medical problems, you know, it's not just about going to clinic and doing what you're supposed to do, but there's this anxiety behind it where things need to be done for everyone to feel sort of safe and knowing that they're doing their best. I think when I was waiting for my transplant, it was like my school project, and I needed to inform myself and feel like I was in charge. I think it's when you feel like you're not in charge that things can start spiraling. Is there anyone here who would like to add something, ask a question? It's been such a wonderful hour with you, but unfortunately it's soon going to come to an end. This has all been recorded and it will be edited, and you will be able to see it again online or share it with anyone who was not able to join us today. And we would be really interested for Transplant Next to have your ideas or needs for what kind of chat we should organize next for everybody. Is there anyone would like to add something? I see Caroline, you have your hand up. Caroline,
yeah. Hi. My daughter was due to come on the Tacker to go skiing just when it got cancelled for the.
I thought I recognised your name.
Hello.
Hi.
And I was just wondering if there was any plans to get that back up and running, because obviously she's 2-3 years older now, and I wouldn't want her to miss out on that experience because she gets too old.
Being too old. Well, you know, with COVID, we had to stop everything that was going on, obviously, and now we've got Transplant Next that's getting on its feet. And once I'm in Perth, I think Ashley, Kim, and I, and Paul will definitely be talking about what to do next with TACAs, which I actually handed from Swiss Transplant to the World Transplant Games Federation. So it will be a World Transplant Games Federation event. What form it'll have and where it will be, watch this space. But TACAs is alive and kicking somewhere and will reveal itself.
Ah, good. Well, we might see you in Australia then, because we're going as well.
Oh, you will definitely see us in Australia. That's excellent news. I'll really look forward to that.
Right.
Anybody else? Thank you, Caroline.
Just a very quick comment. I think, you know, we're talking about a transition. I think that there's almost 3 phases. You know, when you have a young child transplanted or in a chronic situation, the parents tend to be the driving force, and Paul will most probably be more qualified to talk about this. But then as the child grows, and it's quite incredible that you would get 5 and 6 years old, when they've got diabetes and things, they will tell you exactly what it is that they've got and what they need to do, and also youngsters with the medication. But then they grow, and there tends to be a period where it's almost a 50-50. The parents are there, the children are there, and then the transition comes when almost the parents withdraws. You know, they withdraw from the picture, and the young person then has to take over, and that might be also something that one really, and you may have looked at that, Paul, you know, is to actually work that transition better.
I mean, the biggest issue actually is often, for example, going to university. That's a high risk period of things going pear-shaped in the first term at university, and for several people in the UK have lost their transplant in the first term or second term of university, which is a real sad thing. Moving out and living with your girlfriend for the first time is another example. So big transitions in lifestyle, which happen a lot in people in their early adulthood, is a major problem. And one thing I would say, we're talking about transition here, but actually the most difficult group of people to manage are the 17 to 20-year-olds presenting for the first time with kidney failure, because their life is suddenly taken away from them. Whereas the transitioning child is often gone through puberty, successfully doing their exams, in a stable situation, often, not always, but often in their family. And the transition is difficult, and because of the anxieties we talked about, but not as catastrophic as somebody who suddenly has their life and everything taken away from them. So it's a lost group, the 16 to 25-year-old who presents to adult care rather than pediatric care, who is very difficult to manage and finds it very difficult to cope, denies the problem for a long time, and is a very hard individual to manage. That carries over a little bit to some of the transitioning patients who suddenly go completely off the rails for the same reasons. And a state of complacency sets in, feeling that they're invincible and don't need medication, don't need to see doctors. And sometimes you have someone who hasn't been to see a doctor or been to a clinic for 2 years and seems to manage, and then pitches up with a disaster. So this is a real problem period, this 17 to early 20s period for many people, unfortunately. And we have to try and smooth that. But that's why you need the peer support. That's why you need the transplant games. That's why you need TACAs. That's why you need the young patient and the adult patient community. And moreover than anything else, because he can't speak, I'll speak for him, that's why you need somebody who's your advocate, a youth worker, or somebody who can really empathize and support you when things start to get difficult, and support you in the community. It's not just in the hospital. You need community support in that setting, and somebody who's there to help you with that.
Thank you, Paul. I see Alex Gibbs. We're nearly at the end, but Alex Gibbs has his hand up. Alex, no camera. Can you take yourself? Lovely, thank you.
Yeah. So when I was in pediatrics, there was a lot of peer support, and there was a group of us that kind of grew up with the kidney problems, and we saw each other a lot for events and activities. But then we've all transferred, and we've all gone to different units because we were at a centralized pediatric unit. And now we've kind of all been split up, and we don't see each other, and we've kind of lost that group connection. And like in my unit, as far as I'm aware, I'm the only young person under the age of 30 and kind of struggle to find that community again. So how do you think these pediatric centres can manage transitioning to lots of different adult centres?
Well, I think that's where I alluded to earlier. I think that ideally the transition should be to a few larger centres rather than offering every centre. And it is difficult for the smaller centres to deliver the same level of support. And it becomes then a toss-up between, is it worth traveling that extra distance and go, and having that network, or is it worth? And it depends on the individual. Some individuals, seek and would like more peer support than others, and it depends what you want really. And most pediatric, certainly at Great Ormond Street now, and at Guy's Children's, where I do a joint clinic, we offer both options to the individual, but the majority opt to come to our integrated process rather than necessarily going to maybe a unit which is closer to them. But it is a very difficult decision, and it's not easy to follow it up. Social media is a way perhaps you can try and keep your network together. And the other thing, which is a great sadness in the UK, and I'm sure it's true in many countries, is we lose many of these individuals from the transplant games. Children's teams have a high participation rate at the transplant games, and teenagers from children's teams. And many of them, when they're dissipated to different units, don't then see that through because they don't know the individuals in the adult transplant teams in their centres.
Alex, did you come to TACA's?
Yes.
Thought so. That's lovely. Well, ladies and gentlemen, time has marched on and we have arrived at our closing moment. I can't thank you enough for all coming along today or coming online today. I can't thank Ashley and Paul enough for everything they do. It's a real pleasure to work with you. I thank the people that talked about their experiences today. It's been a great pleasure to see people I haven't seen for a long time. Those who are coming to Perth, I really look forward to seeing you all. And those who are not coming to Perth, send me a message and let's get together again soon, wherever that may be. I wish you all a fantastic end of the day or beginning of the day, wherever you are. Send you love and keep healthy, keep happy, and God bless you all. Thank you.